Well, good afternoon, everybody, and thank you for joining us. You've joined us for the CAF COVID Weekly Roundup. Today is September 4th, 2020. It's 1 o'clock in the afternoon. And today we've got a bunch of topics, and we've got a guest speaker as well. So we'll talk about AFLs, some of the AFLs that have come out this week. Deanne's going to talk for a little bit about what the plan is for the ombudsman to come back into the building, talk about a meeting that they had with the Ombudsman Association. We'll talk about indoor air. I know there were some questions on the HAI call, and I can't remember which one it was, but there were some questions in the comments about indoor air quality, and we'll cover some of that stuff today, as well as link you with some resources. As we talk about visitation and indoor visitation, some of that's going to be important to figure out how to safely do that. And so we can consider indoor air for that. We'll get to that in a little bit. And then obviously we're going to touch on the point of care testing devices and the testing AFL, which we anticipate will come very soon. It has not, I checked prior to this, to the webinar starting, so it has not been issued this morning as of yet. So my name is Jason Belden, and I want to thank you guys for joining us. I'm the Director of Emergency Preparedness for CAF. And today we have a guest speaker, Deanne Walters. Deanne's CAF's Director of Clinical Affairs and Quality Improvement. I just didn't want to put the entire title on this title slide. And so she'll be joining us to explain the meeting with the Ombudsman in just a second here. So, and I've been asked by our Public Relations Department to just give a brief introduction of kind of what the purpose is of the webinar, and as well as just to reiterate that sometimes we have speakers, including myself, that may express our own opinions, and that may not reflect CAF's official position. The reason why I say that is because these are publicly available webinars. We know that many members of the media actually watch or listen to some of these. So we want to just bring clarity that if I express an opinion, it is of my own, but we will relate CAF's official position, and I'll try to do a better job of delineating between what's CAF's official position and what my particular opinions are. We have a grant-funded program. Our program, the program that I work for, is solely funded by CDPH and Health and Human Services at the federal level through the Hospital Preparedness Program. I don't have any financial conflicts. I only work for CAF under that grant. The intent of the webinars, and just to be clear, the way we envisioned this was to have a situational report or a sit rep for you guys at the end of the week to kind of, with a cumulative total of all the regulatory changes that have changed that are going to influence your operations. And then we tried to do a little forecasting as we anticipate what may be coming, as you guys as incident commanders or managers of the incident at your facility will need information based on where we anticipate things to go to start moving into building plans and procedures, to make those things happen. And then if we can, we try to highlight best practices. And that's one of the things I've encouraged HSAG as well, because they're a quality improvement organization and they host those calls to highlight best practices that are being used by providers out in the field. And they did a fantastic job on the last webinar by having Dr. Marco from the Los Angeles Jewish Home talk about how they use their point of care testing devices. And so those are examples of the best practices we want to try to have presented to you, whether it be through our webinar or frankly through the CDPH webinar, because there's more eyes on that webinar. So we try to encourage highlighting best practices where we can. So that's the intent of the webinars. It's really mostly to give you situational awareness of what's going on from the regulatory side. All right, so the latest update, and I did miss one AFL, guys. I apologize. When I went to look at the AFLs again this morning, I missed an AFL, and the AFL is 20-46. and that was a revision of the previous AFLs as it relates to emergency staffing. And the only difference between this AFL and previous versions of AFL is, one, it's a little more clear as to the process you go through to ask for staffing assistance. And then also it clarifies what the cost is to you. So essentially the first 72 hours, they're going to cover the cost. After that, there's a scale, a wage scale, depending on the type of staff that are deployed to your facility. And then you would be responsible for reimbursing at that staffing contract rate. Those, there's a link within that AFL. So again, it's 20-46, and there's a staffing contract rate link within that tells you the exact rate that you'd be paying for each staff member that's deployed to you. So I apologize, I missed giving that update. It's not a huge update, but it is worthy to note, and at least print off a copy of it and keep it in case you need staffing resources. Then there was an AFL that was issued a couple days ago about the HSAG initiatives. And what I'd like to do is I'd like to have Deanne talk about it, because she works very extensively with HSAG to see if there's anything actually new about this, or is this just a reminder of the programs that HSAG offers. Deanne?
Absolutely, Jason. Thanks for letting me speak today. Appreciate being here with all of you. So having conversations with HSAG, this is really just a support AFL in order to allow the happier side of helping. Basically, it's gonna help HSAG not run into the brick walls that are happening at the reception when they call facilities. They're not coming in. They are just doing like offsite support and reviews. And through some of the programs that they are doing, they are finding that people don't know who HSAG is, or they're running into places where we're saying, you know what, we don't have time for what you're doing. And so they are working closely with CDPH, and this is their ability then to say, hey, listen, we're here, you should be working with us. And they're out there trying to help us improve quality. So basically, just in the programs that they have, this is a way for them to, when they call you, that they will then say, okay, we know who these people are, it's HSAG, and we should be having this conversation with them in order to, basically help us improve our situation and our care. Right now, HSAG gets a list of about 20 skilled nursing facilities every Friday that they are assigned by CMS to work with. So this just means that if you are part of a group of facilities that have ever had a deficiency, say in the past year to 3 years under infection control, chances are at some point you're going to be on this list that HSA gets. They're going to reach out to you to find out what you're doing in regards to that deficiency, how is it going, and just to do that report back to CMS and to provide you support if necessary in order to improve those outcomes. So it's really just an FYI to ensure that, they're not getting stopped at the door, that people know that HSAG is really doing this because they're supposed to. So we want to be happy for their support and participate as much as we can in order to improve our performance.
Thanks, Deanne. That's much better than I could do. Now, so do they have to fill out that QIIP administrator form if they've not already done it?
It would be really good to do that if you haven't. Basically, it's similar to when CDPH is saying, please assign over your rights for that, the NHSN system so that they can do the reporting for you. So HSAG is going to be able to provide us with a lot of data, but they have to have permission to share it and to gather it. And so we would want them to have as much real data as possible, basically to support us, because we know we're doing a good job out there. We're managing in such a way that we can't keep it out, but we can definitely handle the situation on COVID much better than what things were. And so we want that data to be collected to show that. So by filling this out, it gives them the rights. Now, in the AFL, it specifically says, do not assign them the rights that you gave CDPH, or CDPH will not be able to actually submit that data for you. So be careful which box you check, follow the directions in this very closely so that you don't unassign the conferring of rights to CDPH, but that you also confer to HSAG for the purpose of this data and the data reporting.
Awesome, thank you. I appreciate that. So we'll jump to the next AFL, and even though this AFL came out last Thursday, I think it came out last Thursday or last Wednesday. We mentioned this at the on the webinar last week. We didn't really get into this, but we've got some new information based on meetings that both Craig and Deanne have gone to with the ombudsman. So I'm going to have this is the AFL that talks about the permission of the ombudsman to enter the facility, whether there's an outbreak or not. And then we'll talk in a minute about kind of visitation, outside visitation. We know that was, we know that Heidi really focused on that on the call on Wednesday. So it's clearly very, very, very important for them. And when we talk about, you know, kind of reputational risks, this could certainly be one of them if you've not been proactive in trying to get this worked out. So, Deanne, do you think you could walk us through kind of the ombudsman slides that I borrowed this information from a presentation that the ombudsman gave to us, and I just copied the slides over from some of their slide decks. So maybe you can take us through this stuff.
Absolutely, I'd be very happy to. So I think that all of us were a little bit taken aback when we first saw the AFL that said it doesn't matter what your current situation is within your nursing home, COVID or no COVID, you must permit the ombudsman to come in a facility. And knowing how hard we've been working in order to not, you know, keep out COVID, but just knowing also the situation when you do have an outbreak in your facility, how much time it takes to manage that and to mitigate the spread and how much staff has gone. We're just like, how do you manage the ombudsman on top of everything else? So I think all of us were like in a shock for a moment that this would come out. But we also know, you know, from the side of our families and from, you know, the leadership in California, you know, they feel as if without these set of eyes in our facilities, that all sorts of horrible things could be happening. That personally offends me as a longtime administrator and an advocate for the amazing staff that I have had working with me over the years. But it is the feeling in general in the public that without that oversight, things are just going to go haywire. And in some of the conversations with the long-term care ombudsman office, you know, they said, wow, a few times our ombudsmen have gone in and the residents, they actually look good. They look like they're well groomed and they seem happy. And I was floored the fact that they seemed surprised that even through all of this, that we would still have the dedication to our residents, right? That would allow us to provide excellent care. It floors me that there are people out there that would assume the worst instead of realizing how great people do. So here we are now with this, we're required, we must permit them. So we went to the state ombudsman, made this appointment to have this conference with them just because we know that it is of concern to you as providers, and you know, our membership deserves some answers about how this is going to be handled. So they're going to do a couple of things. So on this new phase one is how they're conducting it. I think everything's phased these days. So right now we have to permit the ombudsman, and we need to not just permit that. We need to be the gracious people that we are and focused on customer service, that when these people arrive, of course, just like any other customer, we're going to treat them with kindness and respect for their responsibility. And so, you know, that doesn't need to be said, but on their side, they feel as if they are getting antagonistic type responses from facilities, or at least that's what they're reporting. And I know that I always try to have a great relationship with my ombudsman. Never was negative or created problems with them. So it's hard for me to imagine that everybody's out there right now, you know, being angry, other than the fact that we want to make sure that they are not bringing COVID into our facilities and that they are being safe. So we need to make sure that all of our staff that are interacting with the ombudsman are very professional. And even when we have to talk to an ombudsman about whether or not they meet some of these requirements, that we're also doing it professionally, because they go back and they report, their interactions with us. And sometimes those reports are one-sided. So we really need to make sure that we have a really good professional interaction with them at all times. So ombudsman can always, meet with residents outside the facility. So on property, outside, right, not coming in. So, those should never be, turned away. We need to make sure that we are taking care of our part and interacting and working with them. So the ombudsman, of course, have both staff ombudsmen and volunteers. And right now, of course, because a lot of the volunteers, as we all know, they tend to be higher in age than you and I. And so a lot of them are very concerned about exposure for themselves, which rightly so, because COVID is really dangerous. So they don't have as many volunteers as before. So they are working on a little bit of a staffing shortage as well. So some of the things the ombudsman is putting in place to help relieve your concerns about these individuals, they've already started and are nearly done with conducting this training before someone comes to a facility visit. So they're going to work specifically around training them on infection control processes. They're going over with them donning, doffing, and disposal of PPE. So again, they should be bringing their own. And we'll talk a little bit of how they know what to bring, right? So they're going to be bringing their own, and they're going to be responsible for appropriately donning and doffing that PPE and disposing of it after any visit. Also, the ombudsman are going to be required to do a self-assessment and affirmation. So some people are doing this like at the door of their facilities. Some organizations and businesses have staff before they come to work fill out, an online assessment, like a doodle poll type thing. So that way they can state that, no, I don't have any signs and symptoms, and that I don't have a fever, and all those kinds of things, and then signing it or electronically signing it as an affirmation to their health and well-being. So those things are going to be happening with the ombudsman before they hit your facility. So if an ombudsman actually needs to come inside the facility, so this is a little different, because all that other stuff, all of them are being trained on, both staff and volunteers. Now, for those that are actually going to come through your doors, these are only going to be done by ombudsman staff. So paid staff, a little bit different here, right? So typically we have our volunteers that come into most of our locations, but because of this, they're only going to have their paid ombudsman staff come into facilities. And they're going to limit what visits there are and prioritize them. So it won't be like before, where I know my ombudsman, he used to come in, and he probably came in once a week as he was making his rounds throughout a couple of different facilities that he was at, and he would chit chat a little bit. He'd talk with me and see what was going on, and he would visit his key residents to make sure everybody was doing well. Well, they're not just going to do that anymore. So they're limiting when they're going to come in. So they're going to come in when they have a report of a serious physical or sexual abuse or a neglect complaint. So just not any complaint, not my food is cold, but these serious complaints, right? Because they also don't want to bring in any sickness to the residents. So they don't want to add to it. So they're only going to come in for these more serious complaints. They're also going to come in when investigation of complaints can't be conducted virtually. They gave an example of a resident who was really hard of hearing, and they just could not communicate virtually, even with the video camera set up. So that ombudsman had to go in, just because it was impossible to conduct this investigation virtually. And then also for facilities where these complaints, their history of complaints are significant, and so they didn't really define what that means, but most of the facilities probably have a good relationship, even if they do have concerns that come in. But if you have an ongoing issue, then expect possibly that you're going to see a little bit more on-site ombudsman than at other times. So for the PPE, so I said that they're going to be trained. So they are using a geriatrician, an infection control expert, and public health officials to create this training that they're providing at this time to the ombudsman. So we're going to now, so they should be bringing it, they should be able to work properly. Does that mean you should still be ensuring that they have the right PPE? Yes. Does it mean you should possibly be observing how they don and doff that PPE? Yes, because if there are any concerns, we need to be able to openly communicate that with the local ombudsman office and let them know that you're seeing concerns with that. So yes, our infection preventionists are going to have to keep their eyes out. You should probably let your staff know if they see an ombudsman and they are not properly utilizing their PPE, that they need to come forward and say, because obviously then that would be putting our residents and our staff at risk. And we want to kindly and professionally report that so that way they can redo the training and ensure that they're using it correctly. Now, the biggest question I know that we all had around the start of visiting was the testing. Now, we all know, and we're going to cover it here in a minute, Jason's going to cover it, the new testing requirements that CMS put out. We have the antigen test machines. We have a lot of things going on. We have the state testing requirements. So what about ombudsmen? If they're going to be coming in, right, we are saying, why should they not also be tested if they're going to be interacting? There is not going to be a requirement for ombudsmen to test that we are aware of, but we have been assured by the director of the long-term care ombudsman program, Joe Rodriguez, that they are going to actively work to align testing for ombudsmen, and this would be staff ombudsmen because those are the only ones that are going to be coming into the facilities. So they're going to align that testing with whatever it is that CDPH is going to be providing us in this AFL. It's not 100% sure what that looks like, but we should be seeing something around testing for them. And again, it probably won't be required, but they want to align with what everything else is happening so that way it looks as if everyone's on the same page for testing and protecting of the residents. So that's kind of where the testing is. Again, not required. So even if an ombudsman doesn't have a test or cannot provide you with a test result, you still have to allow them onto your property. But again, they're trying to align, and so we should start seeing more and more ombudsman staff having that regular testing. So they really want us to work together in order to make this a positive return to our facilities. Again, they feel like it's going to give our families that haven't been allowed in peace of mind that there is someone that is a resident advocate in the facility seeing what's going on. We all know that, you know, in the facilities you're working so hard to be everything for those residents. So we have the tendency, I do, because I'm very protective of my teams, you know, to say, well, of course we're doing a great job. I mean, but they're going to feel better having this advocate walking through. So just know this probably is bringing peace of mind to your family members, and it's going to help, honestly, spread the word around the community that you are doing an excellent job, because it won't just be you or CAF saying you're doing a great job and fighting on your behalf, but now you're going to see the ombudsman who are going to see what a great job you're doing in the circumstances, and that your residents look good and they're well cared for. Do they miss their families? Yes, but otherwise they're doing well. So we really need to facilitate this positive visit when the ombudsman comes to the facilities. And we want to make sure that not only are we open and welcoming, but we need to make sure that we are continuing to report as mandated reporters to the long-term care ombudsman program. There is some question because, of course, the number of complaints have dropped drastically, that we need to make sure that everything we're supposed to be reporting is getting reported. And I am going to go under the assumption, and this is my opinion, that we are reporting the things that we're supposed to report. It's just that we are so involved now with the residents, and the residents are being separated from each other for their own protection, right? That we're just not having as many reports that we would need to make. But we need to make sure that if there is something, that we are definitely reporting it.
Well,
is there another slide on this, or is this my last one?
Well, I think okay. that's the last one, but we can cover the next one together. But I wanted to ask a question before we go forward. Were there any discussions as to who is supposed to do the symptom check? Would it be us, or are we relying on them to self-certify when they come to the building?
So it's going to be both. The ombudsmen are going to have to self-certify with their own, like their own supervisor. So within their own system, every day, they're going to have to self-certify. But do not allow them into your facility without going through your normal screening process. Whatever your mitigation plan policy is for screening includes the ombudsman. So don't assume that just because that maybe they're testing or maybe that they are self-certifying before every shift that they have, don't assume that those things are done. You will still go through your exact screening process. So you're going to check their temperature if that's part of your process. You're going to ask them any question that you would normally ask any visitor in order to assess their right to come in. Because if they have anything, then you still have the right to decline them entry if they trigger any of those things that are in your mitigation plan for screening. Now, on our side, our opinion is you should still ask them, have they had a test for COVID in the past, week, 5 days, just to kind of get an idea. You can ask them if they've completed their own self-assessments. And you can also ask if they've been at any other facilities that day. Now, the ombudsman, I forgot to mention this, the ombudsman said that they will only have their staff come to one facility on any given day. So they should only be visiting your one facility. That way they are not contaminating their person and then going to another facility. So I thought that was another nice protection that the ombudsman office is trying to do, is they will only do that one. We believe that they will also be calling the facility ahead of time, which would be really great to let whoever does normally answer your phones know. The ombudsman might call to say, I plan to visit today, I have this to cover, and it would be really good and good customer service if we were to inform them kind of what the situation is with the facility. If you have an outbreak or if you don't. That would be like number one, right? And then also potentially what your screening requires, so that way they know what to expect when they get to your door. Or anything else that's special that's happening at your facility that they should be aware of before they get there. And of course, it doesn't have to be an entire book worth, because everything seems so different these days, but significant things that they might need to know about before they get there, to help with the transition into the facility and to ensure the safety of the residents.
Yeah, and to kind of piggyback on that, Craig asked us to send pictures of what our facilities look like now, and especially with the setup of cohort zones and barriers and all that stuff. So we forward them on some actual pictures of of how the facilities look different than when prior to COVID. So anything we can do to kind of increase their awareness as to operational problems that they face or that we face when they come visit, I think helps. And you say, look, we've got to do it in this specific room, or we're doing it in this specific space, all of those things. If there's area of the building that you don't want them walking through, for whatever reason, explain to them the reason why. Those kind of things all need to be explained to them. And if you can do it before they get there, that's great.
Absolutely. That communication is going to really be key. And again, making it open and professional so that the ombudsman, are aware of what's going on, so they don't accidentally violate anything on your mitigation plan, and the reasons. Don't just say, don't go there. We want to make sure we're saying this section here is our COVID positive unit. If you go that side, you cannot come back over here. So we need to be aware, and this is a special PPE you need if there's a resident in our unit and that you need to speak with. Again, making sure they understand that once they go into the red unit, right, they cannot come to the yellow or green unit. And so just helping them through that, because you've been living it, unfortunately, for all of these months, but the ombudsman, this will be their first experience back in, and they're trying to prepare them for the changes, because, being so home-like and in such a different environment before to trying to mitigate the spread of this virus is such a big, drastic change. And so they're trying to prepare them, but I don't know that anyone can really be fully prepared for the changes. So whatever you can do as a facility to make it an easier return for the ombudsman in regards to their understanding of the situation would really be helpful.
Well, that's perfect. And that kind of dovetails into what we heard on the CDPH call. And Heidi doesn't make, you know, uh, she pushes things that she wants us as a state or us as all of the facilities to accomplish. And her really, if you listen to her message, she's really, I think she even said you should or you shall have outside visitation. Now I realize not everybody can do that depending on the your facility and what kind of outdoor space you have, staffing to be able to do it, all of that stuff. But it is, it's extremely important for CDPH. This is one of their primary areas of focus, is to get visitors back in to meet with their families. And so Deanne spearheaded a group of folks and created these visitor guidelines or visitor homecoming guidelines for outdoor visitation. That outdoor visitation, given the new AFL, really, this information is incredibly important. So if you've not already started on it, you need to start on it soon. Try to figure out a method, or if not, then you need to kind of quantify why you can't do it, and then start looking at inside visitation, especially if you're in a county with a low positivity rate. We anticipate you're probably going to be looking at doing inside visitation very soon if you're not already. So one of the questions I wanted to ask is if anybody could put in the chat box, are you doing inside visitation already? And I don't need to know the name of your facility if you don't want to put yourself on blast, but I would like to know what counties are allowing that now, if any. And so if you could just put that in the chat box, that would be great. Did you have anything else you wanted to add on the visitor homecoming guidelines, Deanne?
Sure. So, we are required to have outdoor visitation no matter what the status is of your county. That was in that last AFL. So, like Jason said, if you haven't really looked at how to make that happen, and I know your heads are spinning with all the requirements that are going on, but it's really important that we put together a process to make that happen. Now, these visitor guidelines that we put together, we had a group of people, which include family members as well as administrators, and as they are, they might not work for you. So you really need to take a look at adjusting them, of course, but anything that you choose to do, make sure you put it into your mitigation plan and that you provide it to your district office. And really taking a look at the opportunity to do indoor visitation based on your local health department and when they allow that, and really start looking at it now. There are a lot of different things that we can do, but again, it's just really important that we try and meet the needs of the residents to see their loved ones. Too many stories of people that are just giving up because they just miss their families, and we don't need that on top of everything else, but we need to safely be creating these plans within our communities. So please definitely try and set aside some time to come up with them so that there is a way, so that way you're the one creating the process instead of having someone else tell you how to do it. And be proactive and be really open in your communication with your families about what you're doing, because everybody's saying, hey, just open, and then the facilities left to tell the families, well, yeah, but I'm not in a county that can, and so our families get frustrated. So the more open communication you have with your family members, the better everyone's going to feel, and it will help you ease into visiting, whether that is outdoor or whether you can actually do it inside. But definitely look at it. We need to be proactive in making these changes, but doing it safely and on our terms, so that way we can manage it within what we are having to do in our facilities at this time.
And I'll also mention that, that visitor homecoming guidelines that we have, many of those procedures or tasks that are written out in that guidance will be used for inside visitation too. So, my recommendation is that when you start your inside visitation, use this as a kind of a guide. There are going to be many of these things, especially when we talk about symptom check or having one person only or physical separation. All of those things are the same, so we can adopt those procedures and bring them right over. So we don't have to create something completely new for the inside visitation for those kind of procedural things that we would do with outside visitation. So that'll help you get a start to doing that. And then I want to hop to kind of, well, it'll dovetail to that to some extent in terms of indoor air. I know I heard some questions as to, does indoor air affect COVID transmission within our facilities? And while there is no hard and fast data that says, yes, this is airborne and to what extent it's airborne, but it's clear that we can catch it, it stays in our building for a while. And even when it falls, these droplets fall on surfaces, if they're disturbed again, they create something called fomites, which are, you can breathe in the air again. So I don't know where the dividing line starts and stops for determining whether they call this an airborne virus. But clearly there are some elements of this that stay in the air. And so knowing our aging physical plant, what are some of the things that we can do to resolve those kind of indoor air quality issues? And I've kind of tied in a few different resources. This is not by all means a cumulative total of all of the resources out there related to physical plant and COVID-19. But the ones that I've highlighted, especially the one for ASHI.org, and I know I've talked about this before, but they have a tremendous amount of resources for COVID-19, and this is dedicated towards physical plant staff or incident commanders, folks that have knowledge of both the operations of the building and the physical plant of the building. So I watched a webinar from ASHI last night, and even though the webinar was from May, it had a lot of fantastic information. You got to stick with it because some of the information is dated. But as they talk about setting up airflow in rooms or surge rooms, what I want you to do is counsel your physical plant staff to envision that as a visitation room. Forgive me, I got a plane flying over my head. The joy of working from home. So I thought that webinar was really good. I don't think, it's an hour-long webinar. It's free to register. They have a number of webinars. This particular webinar was free, and you didn't have to be a member of ASHI to be able to watch it. I thought it was good. Maybe 30 minutes of the hour webinar was still appropriate. So, but when we think about visitation inside, I want you to think about it in those terms. If we were going to protect somebody in that space, how would we do it from a environmental standard? How would we set up the room? Where would the airflow be directed? Could we get fresh air? Can we exhaust air out of that room to fresh air? Things like that. That webinar will kind of give you an idea of how to plan that out. And if you want to go the extra step and get some kind of HEPA filtration, or if you have like an air scrubber with HEPA filters, things like that, they have real specific ways that they need to be ducted and they need to be implemented. And so it's not as simple as just renting or buying a device and setting it in a room and letting it go. Most of them do require bringing fresh air in from the existing HVAC system and exhausting it through the existing HVAC system. So you have to be careful with those, because it's not just the equipment. There may be some installation issues with doing that as well. If you want a more detailed description of how to do those kind of pressure relationships and airflow relationships, the state of Minnesota, their public health department has created a really handy toolkit. And this is actually something that OSHPD gave me to give to folks. So they thought pretty highly of the the way it was laid out. It is a fairly dense piece of information, but it's less dense than the CDC guidance. And if you're looking for like physical schematics of what a room would look like and where you would have to duct things and do the exhaust and all that, those are covered in that CDC report. But I'll just let you know, it's like 200 pages long of extraordinarily dense information. I would just move right to the diagrams or the designs and use that as a basis. But the information from the state of Minnesota is much easier to read, and it's probably more within the bounds of the competency of our physical plant directors. So many of you guys have seen the K-HAN alert, or if you've not, there's going to be extreme heat this weekend, more so in Southern California, but there's some Central California counties that are going to be impacted as well. So we know there's a number of facilities that don't have air conditioning. And for those that don't, if you're affected by heat, you really have to be conscious about how you're using fans. We want to avoid the use of fans if at all possible, but we know that heat can be an extreme risk factor for our folks. So we want to make sure that we're, observing them to make sure that they're not being affected by the increase in indoor temperatures. But if we do use fans, they need to be installed where the room can be exhausted directly to the outdoor environment, if possible. And I realize that might not be possible. You might not have windows that open, but in my mind, I envision this at the door, pushing air from the hall into the room and exiting out the window in the room. Now, if you don't have an opening window, or for some reason that can't work, you need to look at the way air flows and in terms of clean to dirty. And that's the easiest way I can explain this to you guys, because we don't want fans being set in a red zone or a yellow zone that are causing air to flow in a different direction and pushing air into either spaces where the staff congregate or spaces where there are COVID negative residents. So we need to be cognizant of how we do that. I realize that if you guys have no other choice, rather than, other than, the extreme of evacuation, you've got to do what you can to keep the building safe. But you have to be cognizant of that. If you decide to use, let's say you lose air conditioning or you lose power during this heat wave, and let's say your generator's working fine, but your air conditioning is not connected to your generator. If you have contracts with folks to bring you those like portable move-in cools, just be aware, I don't believe most of those portable move-in cools or the portable air conditioners come with filtration built into them. So you run into the same kind of issue that you do with a fan. And there may be manufacturers of equipment that has both a portable chiller and air filtration, but they're not common. And so the contracts that you may have with a provider or with a vendor to come bring those resources in a power outage or something like that need to be viewed in the same way that you would view a fan. So when you set them up, you have to be cognizant of what direction you're pushing the air, and remember that kind of theory of clean to dirty as we move air around our buildings. I know that this has been an area of focus for some surveyors in certain areas. We've been asked odd questions that I've never heard of before. Like I got one today where a surveyor asked about static pressure drops in their HVAC system to view how effective the air conditioning system is. If you get left field questions about your indoor air, please send them to me so that I can at least view them. It's not that I want to take the folks to task at the district office. It's more that I want to view what they're saying to see if it has clinical value. Or is there information that they have that is not being disseminated? And that's my main concern. Is so I want to know information. There may be folks that have questions you've never heard of before from a surveyor, and that may not necessarily mean it's bad. It just means that we need to take a look at that and understand, why are they suggesting that, and can we learn something from that suggestion? Even if it's not realistic to do what they're saying, they're concerned with both loss of air conditioning as well as the indoor air quality in our buildings. But it's not enough to ask the question. It's what are recommendations for fixing that? And right now we don't have that, other than to talk to you about how to flow air throughout the building to make sure you minimize the infection control risks. So I suppose we'll have a bunch of questions, and I really encourage you guys to reach out to me with any of the kind of one-offs that you get from the survey folks. I won't necessarily take them to task. I want to learn why they're asking that question, to see if there's something else that can be done. So I never look at that as a negative. I always look at it as a learning opportunity, and I think that's a good message we should all have. So I want to get to the point of care testing. Sadly, we don't have an AFL, so this is going to be pretty light. We're still waiting the AFL on these devices. We do know, or we anticipate, that the questions really will revolve around whether we're allowed to do them for screening. And when I say allowed to do it, that's a poor choice of words. We're allowed to use the point of care testing devices now. The question is, what do we do with the results? Can we take action on the results? And that's really what we're waiting on. Right now, it would appear to be we could use the point of care testing devices, but any result when we use them for screening would need to be confirmed with a PCR test. And so until we get the written guidance with the testing algorithm from CDPH, we just don't know yet all of those other methods. I mentioned that it can be used now. So if you have one of these devices, you can use it now. It is being used now under limited circumstances. I mentioned the Jewish Home in Los Angeles was using them, and under a very limited scope, and they went through the scope and why they made the decisions they did. I thought it was great. I wish they could have Dr. Marco explain stuff all the time, because he's really good. So my hope is we will gather that kind of information once we have concrete guidance from CDPH, and present that on whatever the following webinar is after the release of the AFL. All facilities with a CLIA waiver, this is what we know, or what we've heard from AHCA, is that all facilities with a CLIA waiver should have the equipment by the end of the month. Now, we've been told that the facilities that did not have an existing CLIA waiver would not be getting a point of care testing device. Now, I don't know if that's going to change. So if you've not got a CLIA waiver for your facility, don't expect to get a point of care testing devices. And the reason why that's important is you don't even have to worry about POC devices. You just have to strengthen your relationship with your existing lab and continue that. We know that there are going to be reporting requirements. We anticipate in the AFL, the guidance will include the reporting instructions. We had originally sent out the information immediately when we got it from CMS, knowing the effective date of that rule was September 2nd, but CDPH is not going to be enforcing that until they have a chance to define it for us and then teach their district offices about the new requirements. And then one of the other things that people said, well, gosh, how do I find my county positivity rate? And if you look in the handouts for today's presentation, you'll see a copy of the every county in California. There's a test positivity rate index, and that'll tell you, what your county is currently in. And there's another handout for the latest laboratory list from the testing task force. So I know that HHS and CDC have both updated kind of their guidance around the point of care testing devices. And that second link on this page here is a PDF of a testing algorithm that CDC has released. They released it last Thursday night, I believe, or Friday morning. And this clearly allows screening or point of care testing devices to be used in screening with little follow-up for PCR testing. And I'll just say that there are multiple categories you have to go look at to determine what you do after you get a test with the point of care testing devices, but it greatly expanded on what we had previously done. And so we don't know, based on what CDPH has told us in previous calls versus what the CDC guidance is, where the two will align. I don't know. If I had a good idea, I would guess for you guys, but I really don't know. It could be a combination of the two. It could be the CDC thing in full. I don't know. But what I would do is, if I was you guys, I'd take a look at that nursing home testing algorithm, the second link there. It's a one-page infographic, and that's what I asked CDPH to provide with the AFL as a handout. So my hope is we'll get that same kind of testing algorithm that'll inform our decision making. It'll make it much easier at a glance to be able to implement. So I wish I had. Yeah, absolutely. Go ahead.
I'm going to jump in and just say I'm not sure how much Dr. Marco talked about on the other call, or if everyone here was on that with CDPH, but I hear from a lot of sources that the devices themselves have to be hooked up to very specific printers and only use very specific printer paper. And I'm just thinking that maybe some of our listeners today, if they have just set their box aside to wait until there's guidance, that maybe they're unaware of that, and they might want to take their machines out of the box and ensure that they are in line to purchase those printers and paper, so that once they have the roll forward, they can use their point of care testing, because they'll need that in order to print out the results.
Yeah, and that's a great piece of advice. That's one of the things that Dr. Marco and some of the other folks I've talked to, you need to get the box out to see all that stuff. He went through that in detail, as well as, I don't know if you guys were able to get onto the webinar yesterday from CMS. I know they have a recording of that webinar, and they will be doing that webinar again, but the manufacturers of both of the devices were on there and gave a half-hour presentation about all of the ancillary equipment that goes with those devices, as well as kind of the different methods you could use for pulling reports from it, all that stuff. It was very detailed. So if you're going to use it, it's must watch. You absolutely highly recommend to watch it, and it will explain the data cable, the software you need to use, the printer you need to purchase. All of that stuff was in that CMS webinar. So I think they will have a clinical value. And I've said this before, in my opinion, it's incredibly important to pull them out and get them used on anybody with symptoms in your building right now. That's we know that if it's within 5 days of symptom onset, even both of the manufacturers said that's clearly within the scope of these devices. So if you got a symptomatic resident, this is a perfect a thing to use it for. So I do think they will have value, and but it does not mean that they will bypass the lab process altogether. And I want you guys to understand that the guidance is not to necessarily bypass the traditional lab process. CDPH said it's an either or proposition, and chances are you may have to move back and forth or have some kind of blended approach. And that's really what I want you guys to think about, is having that blended approach where you're using it by the testing algorithm, CDPH said, to immediately identify people that could have COVID. It's incredibly important for patient safety. I think it will tell the story in terms of, when we talk about incident command, we talk about a prioritization of our objectives. One of the objectives, even though it's not the first objective, is to protect ourselves from reputational problems or potential fiscal liability on the back end. And I don't know that this will tie into liability. It may or may not, but I do know that this could really harm your reputation if you're assigned one of these devices and you choose not to because it's too complex, or you just choose not to because the state has made it hard. I realize it's a really difficult thing, and this is just going to add one more thing to your guys' plate that you got to figure out. But in terms of our reputation after this, this is probably the most important thing that we need to kind of gather around, and as a provider group or an association, we all need to jump on this and really tackle this testing head on. So, all right. One, thank you guys for joining us. We've got like 5 minutes for questions. I apologize we went long, but I'm happy to answer any questions. Did we have any questions in the chat, Jamie? Or did you have anything else at the end that you wanted to bring up?
No, I'm good to go straight to questions.
Okay.
Great. Well, excuse me. We do have some questions here, so we will start with the first one. Hi, Jason. I asked on Wednesday on the HSAG call about the potential role of fans and/or HEPA air filters, but the question didn't get answered due to time. We seem to put so much focus on cleaning and disinfecting surfaces, but the bang for the buck seems to me to lie in having refreshed air. Other than negative pressure rooms, we don't seem to be guided to do anything. Sorry, I lost my place. We don't seem to be guided to do anything about cleaning or refreshing the air. Okay, so
Yeah,
it's like,
yeah, it's a great point. I 100% agree with you. It's one of the things that when I say we, I mean the pejorative we, but we've not really got a handle on anything between kind of the standard operations and negative pressure, and we haven't. And all of the research I've read has really kind of boiled things down to airflow and making sure that you're moving air from clean to dirty, and increasing potentially increasing filtration within your existing HVAC system or with HEPA filters. Now, those are all what we would call best practices, or nothing in CDC guidance or any of that other guidance. But if you go to like some industry stuff, or you go to the WHO or some of these other organizations, they have, the WHO specifically has really kind of detailed information about indoor air and what you should do, and not just healthcare, but for all types of settings. That information, or that article, is linked on the CAF Disaster Prep website. So we have a separate website that's a grant run website. It's called cafdisasterprep.com. And if you go there, if you look under hazards and you pick infectious disease, I believe it's one of the links there, and you should be able to click on that and go to the WHO article regarding indoor air quality. So next question.
great, thank you. Next question says, in the event of visitors are allowed back into the facility, does the facility have to provide the PPEs for visitors, or should the visitors provide their own PPEs?
Well, my personal opinion is your PPE is probably going to be better than the PPE that folks come with, because they're not going to come with the surgical mask. They're probably going to come with a cloth face mask with their favorite sports team on the front of it, or whatever it is. The point is, yes, you can ask them to bring their own PPE, but I would, if it was me and I had a surgical mask, that's what I would be assigning to them. So. Deanne, would you recommend anything different than that?
No, I think that, our job is to keep our residents safe. And even though I know we're crunched for PPE still, that if we have the availability, that we should be providing the PPE. Now, on this requirement for having visitors, there's nothing that says you have to let everybody in your door. So you need to manage the flow of your visitors, have them scheduled, and schedule them in accordance with how much PPE you have available. So if you are lacking in PPE, you need to schedule less. If you have free flow of PPE, then you can schedule more. But it doesn't say everybody gets to walk in your door. You get to manage that. So don't forget, you need to do it, but you get to manage it so that it's safe for everybody.
Perfect. Next question, Jamie?
Excellent. So the next question is it appropriate to confirm that the ombudsman coming in is on staff and not a volunteer ombudsman?
I'm gonna let Deanne take that one.
I'm sorry, I missed that. What was that again, Jamie?
Is it appropriate to confirm that the ombudsman coming in is on staff and not a volunteer ombudsman?
Yeah, there's nothing that's inappropriate with asking the question. Absolutely. They've told us the only people that will be coming in are staff members, so you can ask. Now, the only problem would be is that if it is a volunteer ombudsman that they've assigned to come to your facility, you can't deny them entry, but you can ensure that they have had the proper screenings, that they've had the proper training that includes both infection prevention and donning and doffing PPE. So you can make sure that we still can't refuse them entry, but they should be staff. And if they show up and they're not staff, then allow them to do their work appropriately and safely, but then you should contact your local ombudsman office to confirm why they're changing something. And then I would definitely send to myself, Patty, and or Jason a note that you're seeing something different than what they are saying is their process.
Excellent. So the next question we have here is, what about congregate dining and activities in the facility?
Deanne, did you want to cover that one, or you want me to take that?
If you want to go ahead and start, that'd be great. I can jump in.
Sure. So we do know that depending on the rate of transmission within the community, you're going to have this local health order that's going to probably limit it. So you're going to want to confirm with your local health department before you make any decision on these visitations. And I apologize, I did not mention that in the beginning, but we're all talking about state guidance here, and you could have independent guidance that's different than that. But when it comes to congregate doing things, I don't know. I'm much more conservative than most other folks, and if I did it, it's going to be in a very methodical manner in which folks are physically distanced and all that stuff. Deanne, did you have any other suggestions for that?
No, I think that the big thing is that we didn't mention, is the local public health orders, which might differ. And so obviously we have to go with the most stringent, but otherwise I think you've got good advice.
Yeah. I'll go two more minutes, Jamie, if you've got another question.
Okay. What happens when the air quality from the fire smoke is in the red? Surely they cannot require us to do outdoor visits, and indoor in a county with over 5% transmission rate makes 0 sense. Please help.
Yeah, no, that's a good point. So I think you can, modify your operations when the situation arises, especially given the smoke that's in the air. Depending on where you are in the state, it's pretty bad. So you would definitely want to let the folks know that are coming to visit, or if you anticipate, outdoor air quality to be unhealthy, you definitely don't want to do outside visitation for that. So, and I think you could probably even make that a policy. Say, look, I'll monitor the AQI every day, and if the AQI is above unhealthy for sensitive groups, I'm not going to have outdoor visitation on those days. I think that's, well within what would be acceptable and probably best practice for you to do.
Absolutely. And Yeah, I agree with you, Jason. I mean, just because they're saying you must do this, it doesn't mean that you then do it when it's unsafe. So your ultimate thing, of course, is the resident safety. And if it's unhealthy air quality, even though your positivity rate is low and so you're not going to do outdoor, then that is a health decision you have to make. Just document it. And the bigger thing is communicate it out to your families. And the reason you're doing it is for the resident safety, that you're going to have to, at this time, cancel or put on hold the outdoor visits because of poor air quality. They'll understand, but we need to make sure we communicate that, because that's usually our biggest failing, is that we don't communicate it out, and then our families get upset, and then they call the ombudsman or they call the state. So we need to make sure just that we're communicating the reasons and what we're doing so that nobody is taken by surprise, because they'll be appreciative of the care that you're taking of their loved one if you're doing it for those safety reasons.
All right, well, that's all the time we got today. We went a little over. I want to thank you guys very much for joining us. Next week, the plan was to have a representative from Medline come talk about the supply chain, but because we anticipate this AFL is going to drop, and it's going to require a lot of real detailed information on how you operationalize it, we may have to postpone that depending on how lengthy the AFL that comes out this week is. So stay tuned. It will be either a full hour of testing, or we'll cover just the testing and we'll talk about supply chain issues. So I want to thank you guys for joining us. I hope you have a wonderful holiday weekend. Maybe you can get 3 days off, hopefully. If not, take care, stay safe, and thanks again.